Welcome to the finale of our Cardiology series, Part 6, Vascular Disease and the Vasculitides. We work through large, medium, and childhood vessel disease, then endocarditis, hypertensive crises, and pulmonary hypertension. Let's finish the series. We start with the large vessel vasculitides. The split is simple. How old is the patient and where is the disease? Both are granulomatous large vessel vasculitides, separated by age. Takayasu arteritis hits young patients, often women under 40, attacking the aorta and its major branches, so you get arm claudication, unequal blood pressures between the arms, diminished pulses, and brutes, which is why it is called pulseless disease. Giant cell or temporal arteritis hits patients over 50, attacking the cranial branches with a new headache, scalp tenderness, jaw claudication, and a real risk of permanent vision loss. The inflammatory markers are high and it overlaps with polymyalgia rheumatica. So you start steroids immediately to save the eye. So young and pulseless is Takayasu, while older with a headache and jaw claudication is giant cell arteritis. Now Polyarteritis nodosa versus microscopic polyangiitis. They sound alike but sit on opposite sides of two big clues, the lungs and ANCA. Polyarteritis nodosa is a medium vessel necrotizing vasculitis that classically spares the lungs. It causes renal artery microaneurysms with a string of beads look, abdominal pain, and neuropathy. It is associated with hepatitis B, and it is ANCA negative. Microscopic polyangiitis is a small vessel immune vasculitis that does the opposite, a pulmonary renal syndrome with hemoptysis, and a glomerulonephritis showing hematuria and red cell casts, and it is p-ANCA or MPO positive. So lung-sparing disease with hepatitis B and no ANCA is polyarteritis nodosa, while a pulmonary renal syndrome with p-ANCA is microscopic polyangiitis. In children, the vasculitis you cannot miss is Kawasaki because of its coronary risk. How do you tell it from immunoglobulin vasculitis and from polyarteritis nodosa? Kawasaki disease is a medium vessel vasculitis in a child under 5 with at least 5 days of fever plus mucocutaneous inflammation, bilateral conjunctivitis, cracked lips and a strawberry tongue, a rash, swelling and peeling of the hands and feet, and a swollen cervical node. The reason it matters is the risk of coronary artery aneurysms. So you treat with intravenous immunoglobulin and aspirin. Immunoglobulin vasculitis is the small vessel disease of palpable purpura on the legs and buttocks, with abdominal pain, joint pain, and hematuria, often after an upper respiratory infection. Polyarteritis nodosa is the systemic medium vessel one with hepatitis B. So prolonged fever with mucocutaneous signs and coronary risk is Kawasaki, while palpable purpura with gut and kidney findings is immunoglobulin vasculitis. Two causes of cold, painful digits, Buerger disease and Raynaud phenomenon. Is this reversible spasm or true occlusion threatening the tissue? Buerger disease, or thromboangiitis obliterans, is inflammatory clotting of the small and medium vessels in a young, heavy smoker, causing real distal ischemia, digital ulcers, rest pain, migratory superficial thrombophlebitis, and even gangrene. The only effective treatment is complete smoking cessation. Raynaud phenomenon is episodic, reversible vasospasm triggered by cold or stress, with the classic triphasic color change of white, then blue, then red, and in the primary form there is no tissue loss. So a smoker with ulcers or gangrene is Buerger, while reversible color changes without tissue loss are Raynaud. Infective endocarditis comes in two speeds, and the speed points to the organism and the valve, fast and toxic or slow and smoldering. Acute infective endocarditis is fast and destructive, abrupt high fever, sepsis, and rapid valve damage, classically from Staphylococcus aureus, which can infect even previously normal valves. In an intravenous drug user, it favors the tricuspid valve. Subacute endocarditis is indolent, a low-grade fever, fatigue, and weight loss over weeks to months, classically from viridans streptococci, settling on already damaged valves, often after dental work or with poor dentition. So a fast, toxic, destructive course with Staph aureus is acute, while a slow, smoldering course with viridans strep on a damaged valve is subacute. When the blood pressure is dangerously high, one question changes everything, including how fast you lower it. Is there acute organ damage? A hypertensive emergency is a severely elevated blood pressure with acute target organ damage. Encephalopathy, stroke, a heart attack, pulmonary edema, aortic dissection, acute kidney injury, papilledema, or eclampsia. You lower the pressure now with controlled intravenous therapy. Hypertensive urgency is the same severe number but without acute organ damage, a well patient with a normal exam, and you bring it down slowly over days with oral medications. The trap is lowering it too fast when there is no emergency, which can cause ischemia. So severe pressure with acute organ damage is an emergency, while severe pressure alone is urgency. We close the series with pulmonary hypertension. Is this primary disease of the pulmonary arteries themselves group 1, or is it being driven by something upstream, groups 2 through 5? Group 1, pulmonary arterial hypertension, is intrinsic disease of the small pulmonary arteries. Idiopathic, heritable from a BMPR2 mutation, drug-induced or associated with scleroderma or HIV, and crucially the left-sided pressures are normal, so the wedge pressure is at or below 15. The secondary groups are defined by the upstream cause. Group 2 is left heart disease with a high wedge pressure. Group 3 is lung disease and hypoxia, like chronic obstructive pulmonary disease, interstitial lung disease, and sleep apnea. Group 4 is chronic thromboembolic disease, which is potentially curable with surgery. And Group 5 is multifactorial, like sarcoidosis and sickle cell disease. So pulmonary vascular disease with a normal wedge pressure is Group 1, while an upstream heart, lung, or clot cause is secondary. Let's lock it in. Large vessel, young and pulseless is Takayasu. Older with a headache and jaw claudication is giant cell arteritis. Medium versus small, lung sparing with hepatitis B, and no ANCA is polyarteritis nodosa. Pulmonary renal with p-ANCA is microscopic polyangiitis. In children, prolonged fever with mucocutaneous signs and coronary risk is Kawasaki, while palpable purpura with gut and kidney findings is immunoglobulin vasculitis. And a smoker with digital gangrene is Buerger, while reversible color changes are Raynaud. Endocarditis, fast and destructive with Staph aureus is acute. Slow with viridans strep on a damaged valve is subacute. Hypertension, severe pressure with acute organ damage is an emergency. Severe pressure alone is urgency. And pulmonary hypertension, pulmonary vascular disease with a normal wedge is group 1. An upstream heart, lung, or clot cause is secondary. That completes the cardiology series: murmurs and valves, heart failure and cardiomyopathy, ischemic disease, arrhythmias, congenital disease, and now vascular disease. Thanks for studying with Mastering Medical.